So, Bismillah ar-Rahman ar-Rahim. Welcome, everyone. Welcome to the session in the ETY Cardiology T2T member program. So this session is going to be about the ECG, the basics of the ECG. And the mentors of this session are Dr. Azza, Dr. Abdel Nasser, Dr. Muhammad, and me, Dr. Zainab. So maybe we can start and ask each one of our mentors to present him or herself. So Dr. Azza, you can start if you want.
Okay. Presenting myself?
Yes, please.
Okay. I work as a cardiology consultant in the electrophysiology at National Heart Institute in Cairo. It's a tertiary center receiving patients from all over Egypt.
Okay, nice to meet you. And then Dr. Abdel Nasser?
Yeah, I'm Dr. Abdel Nasser Manibari from Yemen. I am a professor of cardiology in the Faculty of Medicine, Sana'a University, Yemen.
Okay, nice to meet you. And Dr. Muhammad?
It's my pleasure to share with you the meeting today. I am Muhammad Abdel Basit, lecturer of cardiology at Zagazig University, Egypt. It's a great honor to be with you today for me.
And me, I am Dr. Zain Jaberi. I am an EP consultant from Tunisia. I work in La Rabta University Hospital, and it's really a great pleasure to be here with you all today. So we can start the session. The first part of the session is about the ECG history. Dr. Abdel Nasser is going to present us, is going to talk through a little bit through history for the ECG. And Dr. Abdel Nasser, you can start.
Yeah, actually the ECG is started to work in clinical basis as a clinical ECG machine and was invented by Einthoven in the year 1887. And he got a Nobel Prize for that invention in 1924. Frank Wilson invented another issue, which is the leads from V5 to V6 in 1934, while Goldberger in 1942 invented the augmented peripheral leads, and the American Heart Association in 1954 recognized in her guidelines the standard 12 leads ECG as a fixed and standard tool.
I think Dr. Einthoven died 3 years after earning the Nobel Prize.
Yes, actually, this is fact. Yes.
And then the next part is about the conduction in the heart, and it's going to be presented by Dr. Azza.
The conduction, we talk about the conduction system of the heart, responsible for initiating and conducting the impulse throughout the cardiac muscle. The impulse starts from the SA node, which is located at the junction between the SA node and the right atrium. It's located epicardially. And then the impulse moves in the internodal pathways and to the left atrium across the Bachmann bundle, which is present at the roof of the left atrium, conducting the impulse of the both atria to the AV node. The AV node is the compact AV node is located at on the right side of the interatrial septum. It's anterior to the coronary sinus. It's located at the apex of the triangular cuff, and then it passes to the His system and the His Purkinje system, which bifurcates into the left and right bundle branches. For the next slide, we can show that the AV node. For the next slide, we can show that the AV node is located. The compact AV node is located at the apex of the triangular cuff, which is with its well-known boundaries, the septal leaflet of the tricuspid valve, and the coronary sinus os, and the tendon of Pudar, which is the extension of the Eustachian ridge. With the His bundle, it merges with the His bundle after the AV node, and branching into the right and left system and the Purkinje system on the right side.
Now I will talk about a little bit the technical aspects for the ECG and start with the ECG machines. So the ECG machines or electrocardiograph, it's really an electronic circuit, but what's important in this electronic circuit is the amplifier, and then the paper that is the paper is actually showing the different deflection from the heart, and it might be positive or negative depending on the gradient voltage that is recorded in this machine and amplified, then printed on the paper. So for the ECG, we will get the paper speed that should be 25 millimeters per second. The voltage gain should be 10 millimeters per millivolt, and the filter should almost always be off. The ECG quality is judged by the waveforms. All the waveforms, the deflection that we will be seeing on the ECG paper should be clear and visible, and especially the isoelectric line should be stable. So these are the normal settings and the good quality ECG that we should look for before start to interpret the ECG. What about the filter? So usually we only use it when there is too much muscle contractions that will interfere with the recordings. Otherwise, we try not to use it because it will distort the ECG itself. So all the waveforms that are inscribed into the ECG. And if it's on, we should always mention it on the interpretation. This is the ECG paper, and when we can see into the ECG, it's like a grid. So the ECG grid, it's quite international. The big square is 5 millimeters, and the small ones are 1 millimeters. And we do know when we use the paper speed with the 25 millimeters per second, we do know that the big square will give us like 200 milliseconds, and the small one will give us 40 milliseconds. So this is why it's international to use the same paper speed for everything, and even for the voltage it's the same. So when it's like two big squares, we do know that it's 10 millimeters per millivolt. Then the second part from the technical aspects is about the electrodes itself. So there are like the limb electrodes. They are put into the proximal part from the wrists and the ankles. But what's most important is the left arm. We always should put it like really too far from the heart, because the more proximal to the heart, the more alteration of the wave amplitude we will get in the ECG itself.
Catastrophic the current position, Dr. Lena, of leads. I'd like to add one short story that one patient was sent to me as past time lateral MI, and the problem is that the left lead was in the right side. Just
Yes.
correction of the ECG electrodes, so MI went ago.
Yeah, it's very, very important to try to really stick to the norms. So because, as you said, Dr. Mohammed, the problem when we get the switches with the lead, we really get some kind of misdiagnosis. But maybe there are like few tricks that we can see in the ECG and think about some kind of lead switch, especially with the limb lead switches. So when we get the left to the right, we know that the lead one will be inverted, so it will be more almost negative, and we will see the lead 3 into the lead 2 and the lead 2 into the lead 3. So these are, and also the switch we will get the switch with the AVR and the AVL. So when it's left to right arm, what's like really will give you the hint is when you get the lead 1 negatively lead 1. Then when you get the switch from the right arm to the right left, so up to down, here we will get inverted symmetry between lead 1 and lead 3. So there will be switch and inversion at the same time. But the hint here is when you get the lead 2 that is isoelectric. So you don't even get to see a good QRS on lead 2. It's like a small T wave. So this is the hint for me to say that I'm quite sure that there was lead switches between right arm and right leg. Then we get the switch between the left arm and the left leg or left foot. So this one is really difficult to recognize, actually. So yeah, lead 3 might be inverted, but it's sometimes as like an inferior MI, yeah, we can get some kind of QS pattern in D3, and we are not sure if it's really related to lead switch or something else. But the small hint gets with the P wave. We get like some kind of abnormal P waves in the limb leads that are inverted or maybe some kind of distortion. So, but usually it's really the most difficult type of lead switch that we can guess quite easily, I would say. Then these were about the limb leads. Then we have like the chest leads for sure. It's from V1 to V6. The placements, as everyone already got I mean, we all have seen all of this like from our first year of medical school. It's the fourth intercostal going down to the fifth. And we do know about the additional chest leads. We have like the 7, 8, and 9, and we have from the right side also. But I will add on another lead. It's the Lewis lead. This one is almost perfect to see the P wave when we are, especially with a wide QRS tachycardia, and we have like small P wave. We are not sure if it's there or not. We might do this Lewis lead. So Lewis lead, we will only read it on lead 1. What we will do is we will get the limb electrodes, and we will put the right one in the second intercostal space, the left one on the fourth intercostal space. We leave the foot in the leg. So, and with this, when we read in lead 1, we will get like a really big P wave. It's what we call the Lewis lead. And with as with the limb leads, we might switch leads. With the chest electrodes, we usually misplace them. So it's not really good to put especially V1, V2, because I don't know for my practice, I don't know for you all, but for my practice, usually, especially from the emergency department, all the V1 and V2s are like in the third, maybe second intercostal space. And this gives us a really big problem because it's a poor reproducibility, because I'm not sure if the patient had really like this kind of maybe some kind of ST elevation in V1, V2, and now in my department in the ICU, for example, it's gone. So I'm not sure if it was like some kind of transient ST elevation, or it was related to the misplacement of the leads. So it's really, really important to always check if where were the leads, the chest leads, I would say. But what's more important, like the more we put the leads too far from their normal places, the more we will have like really error in diagnosis. And maybe the last part about the technical aspect is about what is not really 12 lead ECG. We were all talking about the 12 lead ECG. When we record the pseudo 12 lead ECG with the leads that are placed into the torso, we cannot really interpret it as using like the same features that we use for the 12 lead ECG, because we know that with the AVR, especially AVR, AVL, and AVF, we will get some kind of QRS alteration. And even with the precaudal leads, the morphology, especially the amplitude, will change, and maybe the P wave, the morphology of the P wave will change when we put the limb leads into the torso. And then when we record the normal 12 lead ECG in a patient that is set up or maybe even in an upright position, it will also alter the QRS, especially the QRS axis. This is why we do not really interpret the same way the Holter monitoring as the 12 lead ECG, because all of these changes. Okay, then we can.
So I'd like to add you to Dr. Zena one point. If we had inverted P wave in lead 1, it could be true dextrocardia or technical dextrocardia. So we have to look for the precordial leads if there is normal transition of QRS from V1 negative to V6 positive. So it's technical dextrocardia lead switch. But if there is zooming of precordial leads, the same QRS, but getting smaller while I'm moving to V6, so it could the patient had true dextrocardia.
Yes.
Yeah, exactly.
And I have like, it's not my patient, but a patient of one of my colleagues that I had once in my outclinic patient. And I was putting the electrodes, and he said, no, I have dextrocardia. Please put it on the other side. So it's
Switch,
good to,
please.
yeah,
Educated patient. I think
yeah.
he is a doctor.
So now we will move on to Dr. Abdel Nasser, and he
Yeah,
will talk us through the normal ECG.
yeah. Actually, when I say the word all is gold, it's exactly fitting the ECG tracing, and the ECG was its all component is a cornerstone test in diagnosing and in even managing and even sometimes preventive for many cardiac and non-cardiac diseases. And it's a valid tool for emergency medical services and emergency department, the OBDs, the ward, the ICU. So it's an important tool. So when we say all this gold, ECG is very distinctive to diagnose arrhythmias and also to diagnose many diseases like STEMI and non-STEMI, and some electrolyte disturbance could be seen in the ECG. Many diseases could be seen in the ECG. So we'll go for terminology. For ECG, what the ECG looks like. Could I have the second slide, please? Yes. ECG is composed of many waves and intervals and segments, and it has one complex and one point. The waves, of course, when we speak about waves, we have the P wave and the QRST and the T, and then we have the U wave, while the intervals, which is the time interval between two specific points in the ECG, like PR interval or like QT interval, which is very important in distinguishing many diseases. And the segment is the area which is between the two sides, and this is in relation to isoelectric line, which is the horizontal line in the ECG tracing. And the ST segment is a very valid segment, and elevation or depression. It means something abnormal in the ECG, and we have to pay an attention for that. While the BR interval or the segment also is very important. And when we mention the complex, it's the QRS complex, either started by QS or RS, whatever the area will start with. And the transition from QRS complex to the T wave, we call it the J point, and this is very valid for distinction of ischemia or some early regularization issues. Could I have the second slide, please?
So ECG
So
is an objective test, Dr. Abdel Nasser, as you said. It's not like echo. Echo is subjective assessment, but ECG is objective.
Yeah, actually, ECG is very distinctive. It's not like the echo. You have inter-observer variability and intra-observer variability. ECG is very conclusive, and you cannot put other possibility for ECG. And this is the beauty of the ECG. So when we interpret the ECG, we have to interpret the heart rate, but there is some condition for interpreting the heart rate to have, first of all, regular complexes. If the complex is regular, we can use the rule of 300, and we divide 300 by the number of big squares. So if the complex coming after one square, so the heart rate could be 300. If it's coming after two big square, it's 150, and etc. So it will come like 175, 60, and hence that. The problem when there is a variability of the heart rate, so we have to count 30 big squares, which equivalent to 6 seconds, and we count the complexes inside this area and multiply it by 10. It will give us approximately the heart rate within this irregular interval. So this is the first issue to distinguish between the heart rate and rhythm. And for the rhythm, we have to see the B wave is preceding the QRS complex. In another sentence, every B wave should be married to a QRS complex and follow the QRS complex. Sometimes even the shape of the B wave, it's very important. If there is different B wave, we have to consider that as a kind of abnormality. Could I have the second slide, please? So When we speak about the limb leads, as Dr. Zainab mentioned earlier in this presentation, we have the direction of the vector of the heart, and the best area to see the axis of the heart is lead 1 and the AVF. And usually we teach our students that we have 4 possibilities for axis, either normal axis or left axis or right axis or extreme axis, which sometimes we call it no man's land or northwest axis. If the lead 1 and the AVF both are positive, we consider that is a normal area for heart axis. And if the axis is coming like lead 1 is positive and the AVF is negative, so we consider that as left axis of the heart. And then we will go for the right side or right axis where lead 1 is negative and the AVF is positive. The extreme axis, we will find that lead 1 and the AVF both are negative. And all the abnormal axes usually associated with diseases, but not really to be associated with, sometimes it could be plus and minus axis deviation. So this is the problem of the axis. So when we read the ECG, first we have to comment on the regularity of the heart, then we count the heart rate, then we will go for the axis and to see how the axis looks like. Could I have the next slide, please? Yeah, in the next slide, I will talk about the intervals in the ECG, and the intervals could be calculated as a small squares, or even we could count it as milliseconds. And the first interval from the start of the B wave and to the starting of the QRS complex, whatever the wave will start in the QRS complex. Sometimes the QRS complex starts with S waves, and sometimes with Q or QS pattern. So it's still valid. We could call it BR interval. And it's about 3 to 5 small square. If it's shorter, it means abnormality. And if it's longer than 5 squares, it means also abnormality. And the first example or the big example for that, to have a longer BR interval, which is first degree heart block. And if we go for the complex, the QRS complex itself, the QRS complex is about 2.5 small squares, maximally 3 squares width. And if this become wider than 2.5 small square, it means widening of the complex. And the widening of the complex, it signifies interventricular conduction delay, or bundle branch block, could be right or left bundle branch block. And then the QT interval, which is screened like the distance between the Q wave till the T, and then the distance between the RR also is considered, and the QT interval or Q to Q, it should be like 50% or half of that. If it's bigger than that, it means roughly there is QT interval, and we could calculate that on the square root of the heart rate. Exactly, this is how I could read an ECG report. First of all, I should look for the upper part of the page. While the name of the patient is there, I should make sure 100% that this ECG is belonging to the same patient, because sometimes in our community, I don't know, in other community how it looks like, but in our community, because we have a lot of illiterate people, so they don't have to read the paper, but we have to make sure that this ECG is belonging to the same patient. Then the gender also, it's very important, as sometimes normal variant for females or infants will have some variability in the ECG, which is considered normal. And then we will go for the date and time of doing the ECG. It's very important. In cases if you are doing serial ECG or follow-up ECG, you have to check the date and the time for that. Then I will go for the calibration mark. The calibration mark, as Dr. Zainab mentioned, it's about 2 big squares, which is about 10 millivolt. And then I should go for the speed. And the speed, the standard speed is about 25 millimeter per second, and this is regular in our region. But there is some other countries, they are using the speed of 50, so we have to make sure of that. After making sure of all of this instance, I should look, as Dr. Zainab and Dr. Muhammad mentioned at the beginning, AVR. AVR is very important lead, and we shouldn't miss to look for AVR, and it should be negative. If it's negative, we are okay. We have to proceed with the ECG. Then we will go for the rate and the rhythm either to be regular or irregular. Then we will go for the axis, and as I mentioned, axis could have 4 possibilities, and we will go to check if there is any possibility for that. The B wave is very important, and the B wave, the width and the height should be about 2.5 small square. If it's becoming broader than this, and sometimes it takes the shape of M shape or tall and beaky B, this is abnormal. And if it's M shape, we call it B mitral, and sometimes tall beaky B, it will call B pulmonale, and this is signify some other diseases, and my colleagues will talk about that. Then the BR interval, and as I mentioned before, between 3 to 5 small square. If it's shorter, it means some sort of rapid conduction, or if it's longer, it means a slow conduction or block. And the ST segment and T wave abnormality is very important to comment in the report of the ECG. And then we will go for chamber enlargement and bundle branch block, and my colleagues, I'm sure they will talk about this. One important issue here to comment, as you see in this slide here, this is automated ECG machine. Actually, myself, and I do advise my colleagues, don't take the computer interpretation as 100% true issue. You should take it in mind, but you should make your own conclusion and then compare it with what's written. Sometimes funny comment could happen with that. And by that, I will end my presentation, Dr. Zainab.
I'd like to add a comment, Dr. Abdel Nasser, about the importance of B wave, as we had in Egypt. I don't know in Yemen you have a lot of rheumatic heart disease or not. We have patient with asymptomatic rheumatic mitral stenosis. So many patients could seek for ECG just pre-operative assessment, and the only abnormality in ECG is in the B wave. So it could.
Yeah, you are right, Dr. Mohammed. Our country is very prevalent with rheumatic heart disease, and
Yes.
cardiomyopathy also in between. But ECG or in non-cardiac surgery, our preoperative issue is a clue to diagnose many cardiac diseases by ECG. So I agree totally with you that not only B wave, any abnormality in the ECG could pay the attention of the doctor to a cardiac problem with this patient.
Well, thank you, Dr. Abdel Nasser. Thank you, Dr. Mohammed. So, Dr. Mohammed, I'm going to ask you, how would you approach an ECG? How do you interpret an ECG usually?
Actually, I educate my student and colleague to simplify the ECG interpretation as much as they can, not to miss an important item in ECG. At first, after finishing the basic part of calibration and speed, they must check for rhythm, rate, and axis. By rhythm and rate, they will get if there is any form of arrhythmia or not, as all of us know that arrhythmia is any rhythm other than normal sinus rhythm, which is between 60 and 100, and regular arising from SA node. Any rhythm other than that, it is arrhythmia. If there is any form of arrhythmia, we have to move for the part of arrhythmia interpretation. But if there is no arrhythmia, there are 3 major topics not to miss. Number 1, bundle branch block, chamber enlargement, and ischemic heart disease. Bundle branch block simply, for sure all of us know that bundle branch block means wide QRS. Wide negative QRS in V1, it's most left bundle branch block. Wide positive QRS in V1, it is the right bundle branch block. Then chamber enlargement, either atrial or ventricular enlargement, looking to the B wave. If there is tall B wave in the inferior leads, more than 3 millimeters, it is B pulmonale or right atrial enlargement. If it is broad B wave, B mitral, it is left atrial enlargement. If the width is more than 3 millimeters. Chamber enlargement at the site of ventricular enlargement, simply we look to V1 and V6. It is the simplest criteria. If there is tall narrow V1 in tall narrow QRS in V1, it is mostly right ventricular enlargement. I know there is broad differential diagnosis for that, but simply it is right ventricular enlargement. But if V1 negative and V6 positive, we have to count V1S and V6R. If there is the sum of large squares in V1S and V6R is more than 7 large squares, it is mostly left ventricular enlargement. If less than 7 squares, it is normal. Then moving to the ischemic heart disease, looking to the J point, which is the junction between QRS and ST. If there is J point elevation into contagious leads, or J point depression, it's ST depression, or just T wave inversion into contagious leads, it is suspecting ischemia or acute infarction. But there is some trick in V2 and V3 that depend on age and gender. If the patient is male more than 40, we use cutoff value 2.5 millimeter. If this age below 40 and male patient below 40, we use cutoff 2.5. But if it is more than 40, we use only 2 millimeter cutoff point in V2 and V3. If there is female, we use 1.5 millimeter cutoff value. The important step is to regularly check posterior leads and right ventricular leads, as Dr. Zainab said, in all patients with acute chest pain, and using cutoff value 1.5 millimeter elevation only in posterior leads and right leads could diagnose acute infarction. This is the simplest way to think of ECG, to think of the 3 major topics other than arrhythmia, bundle branch block, chamber enlargement, and ischemic heart disease. But if there is arrhythmia, we could move to the next slide to see how we could approach patient with arrhythmia. We have to check the B wave, the French school cherchology, if there is single atrial activity before each QRS, or single but multifocal atrial activity, more than or equal 3 different shades of atrial activity, or there is multiple atrial activity before each QRS, or undetermined atrial activity. Starting with single unifocal atrial activity, again, we will check the atrial rate. If the atrial rate below 60, it is mostly sinus bradycardia. Between 60 and 100 is normal sinus. More than 100 could be sinus tachycardia or atrial tachycardia according to the morphology of B wave, either rising from SA node or not. And we could check for occasional irregularity, check for short PR interval or long PR interval, especially in sinuses. Moving to the second slide, if we could face single multifocal activity, atrial activity before each QRS, so SA node is not working, which is basing for the atria is more than one focus. If the atrial rate below 100, so it is wandering atrial pacemaker. If more 100, it is multifocal atrial tachycardia. As we know, it is very common in patients with COPD. Moving to the third slide, if we couldn't find atrial activity, it is undetermined atrial activity. Simply, we could check for irregularity. If there is irregularity, it could be atrial fibrillation, whether it is narrow or wide, and wide due to bundle branch block, aberrant conduction, or pre-excitation. If it is regular complex, so we'll check if it is brady or tachy. Brady, it will be junction rhythm or AV nodal rhythm. If it is tachy, it could be tachycardia or flutter. We'll check for the complex. Wide complex tachycardia is ventricular tachycardia until proved otherwise, as there is differential diagnosis for that, such as supraventricular tachycardia with aberrancy or supraventricular tachycardia with underlying bundle branch block. But I'd like to educate our colleagues in CR that you have to deal with wide complex tachycardia as ventricular tachycardia until proved otherwise. If it is narrow complex tachycardia, it is supraventricular tachycardia until proved otherwise. But we have not to miss fascicular ventricular tachycardia, which is about 100 and 20 milliseconds in width. Moving to the last algorithm for arrhythmia interpretation, if we face the multiple atrial activity for each QRS, again, we'll check the atrial rate. If atrial rate below 100, it's EV block for sure. Between 100 and 240 or 50, it's atrial tachycardia with EV block. If it is between 250 to 400, it is atrial flutter with EV block. If it is more than 40, it's coarse AF. After finishing that, we have to check for AV association or dissociation. If there is
Mohammed?
in activity, it's complete heart block. I think it is 4 slides approach. You are hearing my voice?
Yeah,
The last
it was
slide,
that.
Dr. Mohammed.
I think internet interrupted last few seconds.
Yes, exactly.
I repeat such multiple atrial activity, or it's okay?
Yes, you should repeat it because the important part was missed.
So this is the last slide algorithm for interpretation of arrhythmia. If we face the multiple atrial activity for each QRS, we have to check the atrial rate. If the atrial rate is below 100, it's EV block. If the atrial rate between 100 and 250 or 40, it's atrial tachycardia with EV block. If it is between 250 and 400, it is atrial flutter with EV block. If more than 400, it's coarse AF. After that, we have to check if there is AV dissociation or AV association. So to decide which type of block is present. If there is AV association with fixed intervals between atrial activity and ventricular activity, so it's a second degree AV block. If there is complete dissociation and the variable intervals between atrial and ventricular activity, so it's a third degree AV block. The nice trick here is in AF when the QRS is regular, it is a sure sign of complete heart block in presence of atrial fibrillation, as irregularity of the QRS is the sign of association between the ventricle and atria in presence of AF. I think it is simplest approach for undergraduate student and intern doctors to approach ECG. After finishing such basic algorithm, they must search for others, and others, it is a big word that could have more details, more than such simplest algorithm.
Thank you, Dr. Abdel Nasser. I will add on actually with sometimes we do have some ECGs with like the heart rate. The heart rate is around like 110, 100, 110, something like that. And it's actually an atrial tachycardia because with a 2-to-1 block, because you have like one P wave that is preceding the QRS and the next one is at the end of the T wave. So no one will notice it and they will like just say that it's a sinus tachycardia. So we do get.
Do you use ivabradine in such sinus tachycardia and 2-to-1 block?
Actually, when sometimes it's an actual atrial tachycardia with a 2-to-1 block. It's not really sinus. So, but yeah, for inappropriate sinus tachycardia, we do prescribe ivabradine. Depends,
I
but yeah.
faced a couple of patients with about 70 years old with inappropriate sinus tachycardia and 2-to-1 block. So the atrial rate, SI nodal rate was 120, and if the ventricular rate was about 60. After prescribing ivabradine, it comes to 1-to-1 conduction at a rate of 80 or 75.
Okay, well,
But
that one was.
Sure, if it is atrial tachycardia, the management will be different.
And sometimes it's not even easy to diagnose it on a ECG because you have like the atrial rate is around like 240 and the actual ventricular rate is around 110, something like that. And a lot of students will miss it and will say that, especially with the ones that coming near the sinus node. So the P wave morphology looks like the sinus node. So quite tricky sometimes.
Yes.
Okay, so maybe we can move on to Dr. Azza, and I will ask you, Dr. Azza, to talk us through your approach to interpret an ECG, your systemic approach.
Okay, after all these nice presentations about the ECG, we have to come to the end to summarize what we have said in the previous lectures. We have to have a systematic approach to interpreting ECG. Before evaluation of any ECG, we have to check the following, as Dr. Zainab said before. We have to check for the standardization, the leads shown. We have to review for reversal of leads, the right chest leads, and the half voltage standardization in left ventricular hypertrophy. Step 1, we have to check for the rate. If it is if the rate between 60 and 100 beats, so if it's less than 60, the patient is bradycardic, or if it is more than 100, is tachycardic. We have to check if it is what is the rate. Step 2, checking the rhythm. We have to look for the presence of P waves. Is there a P wave coming from the SNU, sinus P wave? And then if every P wave is followed by a QRS complex, and the QRS complex have in every P wave, or the P waves and QRS complexes are regular, and if the PR is constant, then comes the third step, step 3, looking for the axis. It is normal axis, or if it is left or right axis, as Dr. Abnasser had explained. And then comes step 4 for the intervals. What is the PR interval? If it is normal for 120 to 200 milliseconds. If it is short, we have to think about the presence of an accessory pathway. If it is long, we have to check if there's any form of block across the EB node. And then comes the QRS interval. If it is a long QRS, a broad one, I mean, does this denote the presence of an accessory pathway or a bundle branch block? Or if the patient is paced, or if the patient is going into ventricular tachycardia. And then we check for the QT interval. If it is normal or a short or a long QT might be present. Then comes step 5. The P wave. What is the shape and axis of the P wave? The P wave morphology should be examined to determine if the rhythm is sinus or coming from another atrial location. The amplitude and duration of the P wave, as Dr. Muhammad had hinted for, the P wave might be just a clue for mitral stenosis, for instance. If we have a left atrial enlargement, determine if there is a left and or a right atrial enlargement. Then comes step 6, looking. Then comes step 6, looking for the QRS complex. It is wide. If so, examination of the morphology can determine if there is a left or right bundle branch block or pre-excitation present. In addition, we should look for the voltage if it indicates a left or right ventricular hypertrophy. The Q waves present is suggestive of infarction. If there's QRS notching, that will represent myocardial disease. And then looking for the ST segment and the T wave, if there's ST segment elevation or depression, compared to the T2P segment. The T2P segment between the T wave of one beat and the P wave of the next should be used as the baseline. Looking for the T wave if it is inverted on which lead, and abnormalities of the ST segment or T wave might represent myocardial ischemia or infarction. And then overall, we have to get a full description of the ECG in order to get a proper diagnosis. This description may state for the rate, for instance, if it is rapid and irregular. Does this mean if the patient is having atrial fibrillation? If he has ST segment elevation in the inferior leads, for instance, with ST segment depression in lead 1 and APL, this might represent an inferior infarction with the reciprocal changes. And so we have to explain the full picture at the end to be interpreted for the proper clinical diagnosis. The next, please. And so I'm describing to get a proper diagnosis at the end, to have in order to say if this is a normal ECG, we have to look for the P wave, for the QRS complex, as I said before, for the intervals, in order to get a final diagnosis for a normal ECG. Another ECG, the next one. For instance, here we can see just some examples of what we were saying over these presentations. For instance, we can see here how, looking at lead 1, we can find that this P wave inverted and the QRS. What does this denote? But if does this denote a reversal of leads or not? But if you continue to look for the rest of the ECG, we will find. I'm sorry. For the rest of the ECG, we look for the precordial leads. There is no progression of the arc wave, and so we have to think if this is dextrocardia or this is a part of a reversal of leads. Next slide. Another ECG where we can see that the patient had the ECG chose a normal P wave with a normal QRS and a normal T wave in the lymph leads. However, in the precordial lead in V1, V2, and V3, we can see that there's a rapid transition for a tall R between V1 and V2, and then it goes back for V3, having a small R, which is one that has been described by Dr. Zainab, with the reversal of the precordial leads. And then another example for the ECG, where we can see, for instance, the presence of a sinus. Actually, it's a sinus rhythm, but we have a peaked P wave denoting the presence of peak pulmonale with a tall R in V1. Does this have a right side dilatation with an elevated pulmonary artery pressure? Meanwhile, we have a biphasic or a left atrial enlargement in V1. Does this mean that this might be a clue for mitral stenosis, for instance? And so looking carefully to the ECG can give us some clues before sending the patient for echocardiography. To the next ECG. Another ECG where we can see what's striking for this ECG, we can see voltage criteria in the ECG, tall R waves in the lymph leads and in the precordial leads. And so we have to check for the standardization of the lead. Is it normal standardization or half standardization, so that we might be sure in our interpretation if this is actually hypertrophy or just we have the calibration that is not normal. For the next ECG, another one where we can show that very short PR for instance, it might be the clue for the presence of an accessory pathway. And so looking carefully and interpreting the ECG in a stepwise manner would lead us to get a proper diagnosis for the patient. For instance, if we can look at this ECG in a very systematic way, we can see that it is a wide complex rhythm. We cannot identify a P wave in this ECG, and so it is not a sinus. This patient is not in sinus rhythm. Meanwhile, it's a wide complex rhythm with irregular RR interval, with having a peaked T wave in the precordial leads. And so we can get a lot of clues in the ECG. It's not just interpreting in if it is tachycardia or not. If the patient is tachycardic, the patient is not in sinus rhythm. But meanwhile, we can, while looking for the T wave, which is tall and peak, this might be a clue for an electrolyte imbalance. And so we have to look for every point in the ECG in a stepwise manner so that we can get a proper diagnosis.
Okay. Well,
thank you.
Thank you, Dr. Aza. And now it's my turn again, maybe to talk you all through abnormal ECGs. So I'm gonna go to that part. I'm gonna talk about a non-exhaustive list of abnormal ECGs because abnormalities as like it can start with the P wave till the QT interval. So I'm just gonna talk you through two parts. It's about the blocks, like not the blocks between the A and the V, but the blocks into the A and the blocks into the V. And then we will talk about hypertrophy. So I'm gonna start with the anteroventricular block. So the block into the V, so the conduction into the V. The first one is the fascicular blocks. So we do know that there are, as Dr. Aza already talked us through, the conduction in the heart, and we saw that the left bundle, we do have like two fascicle, and we have the anterior one, the posterior one. We might get the block into the anterior one, and usually it's, do you see the one? Yeah. So usually it's we do get like the shift into the axis that goes up leftward. And in AVL, we will get the QR pattern. So in AVL, here we will get like small q with a big R. And especially we get like if we measure from the beginning of the QRS till R peak time, we will get a duration more than 45 milliseconds. So this is what we call prolongation of the R peak time. So more than 45, and the Q, the small Q that we get in AVL. And then with the fascicular blocks, we never get a QRS more than 120, whether it's the anterior one or the posterior one. Also, the QRS is always less than 120. For the posterior fascicular block, we will get the axis, will go more rightward. So it might even get into like 180. And the hints here, we will get like a big S wave in lead 1 and AVL, and the Q deviation like in lead 3 and lead AVR. So if we see here, lead 1, lead AVF, it's a small r, big S. So the big S in the lateral, the high lateral leads, and in lead 3 and lead AVR, we will get even AVF more, but the lead 3 we will get like the small Q wave and the big R. Then we have like we might get the block in the proximal branches. So it might be in the left or the right. But the common features here, which is different from the fascicular blocks, is the duration. If it's in adults, it should be more than 120 to say that to conclude that it's a complete bundle branch block. But if it's like between 110 and sorry, here it's 120. So if it's between 110 and 120, we might say that maybe it is incomplete bundle branch block. So how to differentiate between the left one and the right one? I usually look like only to V2, V1, V2, and V6. So we do know that if it's left, we will get like a QS pattern in V1, V2, but broad and notch R wave in V6. And it's more or less inverted with the right bundle branch block. So with the right bundle branch block in V1, we will get more Rs, and in V6, we will get more negativity. So this is what we call the S wave that will be prolonged and bigger than the R wave itself in V6. So why do we get this kind of patterns? For the left bundle branch block, we do know that we have the block here. So when we are trying to record the electric activity from the heart, looking from V1, everything is going to the other side. But this is the first part. But after that, the latest part that will be activated in the left ventricle, it will be like the lateral part, and it will be very late because of initially the block in the left bundle. And so because of that, the QRS will be prolonged, and the axis of depolarization is not changed. So the V6 will stay positive as normal ventricular activation. But the difference is this part, this last part, will be notched, and just because of the late activation due to this bundle branch block. With the right bundle branch block, the ventricular activation will be shifted, especially for the RV. So in V1, there will be like the first part of V1 will be normal, but the last part from V1, we will get this prolongation in QRS, but the last part will present the depolarization of the right ventricle that will, it won't be depolarized till the vector will, till the vector comes from the ventricular, from the left ventricle. So the first part will represent the depolarization of the septum and the left ventricle, and the last part, looking from V1, will represent the depolarization of the right ventricle. And it's the same for V6. For V6, we will get this S wave plus, because of the latest activation from the RV. And we do know also that we do have some kind of intraventricular conduction disturbances that are unspecified. We cannot say whether it's left fascicular block or maybe right bundle branch block or LBB. So we will say that this is unspecified. The duration should be always more than 110. But usually the pattern for this kind of intraventricular conduction block, it will be like a QRS in all the precordial leads. So starting from V1 till V6, we will get like a small R, big S, or maybe just QS pattern. So this was the part about the block, intraventricular block. Then we have the chamber hypertrophy. The chamber hypertrophy, we can get like hypertrophy in the LV, in the RV, in the LA, and in the RA. Noting that in semiology, we will say like LA hypertrophy or RA hypertrophy, but it's not really related to the muscle hypertrophy. It's more related to what we call chamber enlargement. If we start with the LVH, LV hypertrophy, there are like a lot of criteria. It's like around 27 type of criteria about the LVH, and we can classify them into voltage criteria and indices. But it's really complex. I mean, even when we try to follow each type of criteria, we are never sure whether it's really related to hypertrophy or something else. This is like an exhaustive list of the criteria that we might use to conclude about AVH, yes or no. This is from the AHA recommendation from 2009. But to make it simple, I would almost usually use the voltage criteria, as Dr. Muhammad already talked us through. We usually use the Sokolov and the Lyon criteria. You just look for V1, the S in V1, plus the R in V5 or V6, and you might conclude whether if it's LVH or not. And we do have also the simpler one, also the kernel voltage. You look for the S in V3 and the R in AVL. About the indices, actually, they use a lot of. It's more composite of several criteria. So it's the QRS duration and the amplitude of the QRS to say whether it's more LVH or not. But you can also use some kind of regression equations using the criteria from the ECG and the criteria from the patient itself. It depends on the age, on the BMI, and on the gender also. So these are the criteria for the criteria from the QRS. But we do know that with the hypertrophy, we might get the some kind of ST and T abnormalities. It's what we call secondary repolarization abnormalities. And it used to be called typical strain or strain pattern. You just need to look for the G point. There is some kind of depression, and you get the downsloping depression of the ST after that, and an inversion of the T wave that is always asymmetrical. Then for the right ventricular hypertrophy, there is also a lot of criteria, and this is from the same recommendation from the AHA back to 2009. But we do know that these criteria have like some kind of variable accuracy, but most importantly, these criteria are really recommended and really accurate for the definition of RVH in congenital heart disease. But the lowest accuracy is with chronic lung disease. To note that we do have some kind of what we call ECG patterns for RVH. So there is the volume overload and the pressure overload. How to differentiate them? It's just to look for the QRS morphology. When it's volume overload, it's more RSR prime pattern. When it's a pressure overload, it's more just like an R wave, a tall R wave in V1 and V2. But for the axis, it's the same. And noting that even for the right ventricular hypertrophy, we might get some kind of secondary repolarization abnormalities, but it's more frequent with the LVH than the RVH. This is an example of RVH. So we have like the RSR pattern that resembles the Vandenberg block and even the S wave, but this is coming from a patient with hypertrophic cardiomyopathy. So we do know it's not really about the Vandenberg block, but it's more about the RVH. And we do see the ST and T abnormalities related. Then we go back up to the atria. So we will talk about the atria enlargement or hypertrophy, but also we will talk about the blocks into the atria. So this is like the simplest table to classify whether we do have right atrial enlargements or left atrial enlargements. We will look only like for lead 2 and V1. For the ventricular enlargement, or hypertrophy, we looked for V1 and V6. Here we will look to lead 2 and V1. And it's quite easy. For me, back to medical school, I used to memorize this one, and it's easy. For the left atrial hypertrophy, it's more like a double-peaked P wave that is longer, more than 120 milliseconds, and we do know that the axis of the P wave will shift more leftward. And in V1, this is like a suggestive sign. It's not really specific. It's more sensitive than specific. But usually with the LAH, we will get a pure negative P wave in V1. Noting that in patients with decompensated acute heart failure, we might get this also, but it's not really related to a real LA enlargement. So this is an example of an LA enlargement. So you can see that in V2, we've got the double-peaked P wave, and in V1, we've got like the predominant negative part, the second part of the P wave that is predominantly negative. Then for the array enlargement, the P wave is usually quite high. So it's in V2, it will be tall, even peaked. And V1, V2, it is the initial part that will be positive will be very prominent. And the P wave usually get the rightward shift axis. Then when we might get a biatrial enlargement, so the P wave will be tall and wide in lead 2, and even only peaked, only positive in V1, V2. Then we have the interatrial block that we might get in the ECG, that we might see in the ECG. The criteria are a P wave that is wider than normal, especially in the frontal plan. And in lead 2, it will be bimodal. So we've got like a positive part and a negative part in lead 2, which is abnormal. Usually in lead 2, it's only positive. And the P wave in V1 might get even only positive, but maybe sometimes a small negative part. And still to be covered for the ECG abnormalities, all the abnormal rates, rhythm, the PR and the interval, the P2R relationship, the ST and T wave abnormalities. But all of these will be covered by our colleagues during the following sessions with the bradycardia, tachycardia, and acute coronary syndromes. So the next step is the auto evaluation that I invite everyone to start with from now on. Thank you. So